Thank you. So first and foremost, thank you so much for having me for this very interesting session. I learned a lot from the previous two talks. So what I'm going to do is I'm going to discuss it. This is going to be a summary of the two things which you already talked about. You had the Dr. Joe talk about the his use of CGM, and we had Dr. Unni sir talk about this. This is sort of an amalgamation of both the things, in a sense, Indian version of Dr. Joe's talk. So here we go. So using professional CGM for calibrating glycemic control, this is what my talk is going to be about. So this is the outline of my talk. We are going to classify the various types of CGM. We are going to talk about using the right device for the right patient. We'll discuss the indications for use of a professional CGM. We'll talk about our own workflow for the use of CGM or a professional CGM. And we'll, in the end, top it up with some very interesting use cases for CGM. So, frankly speaking, CGM has moved over a period of time, and the classifications have also evolved over a period of time. So, this is the current classification for CGM devices that are available in India. So, you have three types of CGM. You have a professional CGM, which is Medtronic iPro 2, and the very famous Abbott Freestyle Libre Pro. Most of my talk is going to be about Libre Pro because that's the one which is most popularly used in India. The second is the Flash CGM, that's the Abbott Freestyle Libre, which is the newer version of Libre Pro, which is now available in India. We still don't have Libre 2, so we are still far away from that. And then you have the Real-time CGM, where you have Medtronic's Guardian Connect and you have the Dexcom, both of which are available in India, but they are on the cost is on the higher side, and hence it's a little prohibitive to use. The other way of classifying CGM is based on blinding. So you have the blinded CGM and you have the unblinded CGM. The blinded CGM are basically professional CGM. So these professional CGMs are the blinded ones, and the Flash and the real-time CGM are generally unblinded ones. So again, this is a older classification. The same way, these are also classified as retrospective CGM and real-time or prospective CGM. So these are another way of classifying CGM. Now, in the West, where Dr. Joe practices, and in the West, basically retrospective CGM is now going out of the market. The professional CGM or a retrospective CGM is going out. One big reason is this paper. Actually, this paper is a landmark paper in a sense, which is, the image itself is so terrifying that there is, in the West, they have probably discarded the use of a professional CGM, while in India, we still continue to use it, and there is good use cases in India. So I think, it's an overreaction in a sense to that. But this is a paper, and you can see here what happened in this patient. Basically, this patient was on a retrospective professional CGM device, and the patient actually did not see the morning. So they took the CGM and they analyzed the data, and what they found was that the patient died because of a severe hypoglycemia. So you have the full paper available. I've just taken one screenshot of the one very terrifying picture you have here. The problem here is that this one person life could have been saved if this was a real-time CGM, where you could have got a warning straight away saying that the patient is going towards hypoglycemia. The patient would have woken up and taken counter-regulatory measures, and perhaps a death could have been averted. So this is the reason why CGMs which just give a retrospective data have become a little bit less popular in the West because of the inability to really pick up the signs which are very vital for a patient with type 1. However, having said that, using the right device for the right patient is what Indians do all the time. We believe in, like Dr. Unni sir said, in Jugaad. So we believe in using the right technology or the right device or the right strategy for the different patient. We have to be creative in that sense, because all patients will not afford everything, all patients may not be ready for everything, and there are a lot of challenges which we have to face. So the three major types of professional CGM device that we have internationally, these are the three. I'll again not go into too much detail about these ones, but you have the Abbott Freestyle Libre Pro, you have the Dexcom, and you have the Medtronic device iPro 2. Now, of these, the Dexcom G6 is a hybrid device, so it can be used as a professional as well as a real-time CGM. The other ones are pure play real-time retrospective professional CGM. Of these, Abbott Libre Pro is the one which we use the most, and it has the longest time as well. It gives you a 14-day reading. Dexcom G6 gives a 10-day reading, whereas a Medtronic device gives a 6-day reading. All of these devices are, they are placed, the Abbott Freestyle Libre is strategically placed in the upper arm, whereas the other two can be placed in the abdomen. And you have, of course, different ways in which you can take the data and take it forward. So like I said, you need to use the right device for the right patient. So for a patient with type 1 diabetes, or a patient who is having a pregnant patient with gestational diabetes on multi-dose insulin, or a patient on basal bolus insulin, or a patient on steroids with very fluctuating sugars, all of these patients require active calibration. And when you have a patient who requires active calibration, that patient requires a real-time CGM or a flash CGM. Whereas there are the majority of our patients are type 2 diabetes patients, like Dr. Unni sir said. Some of these patients are on many of these patients are on oral antidiabetics. Some of these patients may be just on a basal insulin. In such patients, the use case for use of CGM is basically to fine tune the glycemic management, right? To enhance, to give an added value, to actually open our eyes to what the patient is doing. And this is where, again, a lot of our patients fall in this category, and this is where the use case for real-time CGM really lies. So basically, we use professional CGM in our practice for fine-tuning glycemic control rather than to build a treatment program, right? So the idea is to basically, our treatment program is set, but what we use it is like a good chef, we use it to garnish the glycemic control, to improve the glycemic control, to give that extra edge, to give that extra X factor for improving the glycemic control, rather than to build the entire glycemic control based on the pure CGM data. So that's the difference. That is how we really use professional CGM in our practice. So I'll give you a clear-cut example to really understand how professional CGM gives you a deeper insight into your patient profile, right? So let's take 3 patients. All these 3 patients have similar average glucose and have same HbA1c. So all of these 3 patients have an HbA1c which is close to 6.8%, right? So this is a patient. This is patient PCM, right? The average glucose is 144, right? You can see the CGM data. So you can see overall the patient is doing reasonably good. There are less glycemic variability in terms of intraday as well as interday variability. However, the patient, we did realize that the patient has a post-evening snack, there is a rise, so there is a pre-dinner surge in glucose. And I practice in Gujarat. I am a Gujarati myself, and Gujaratis love evening snacks. I mean, you can take anything away from a Gujarati, but you can't take an evening snack away from them, right? And this is a pertinent problem for for Gujarati diabetic patients, that evening snack with a cup of tea produces a pre-dinner high, which we could easily pick up in the CGM. And of course, I could not take away the evening snack of our patient, but I could give him some low carb options, which really help the patient in the long run. But take a second patient, right? This is patient initials of BPP, and look at his average glucose. His average glucose is again 145, very similar to this patient. This patient also had an HbA1c of 6.8. But look at this patient's overall profile. Visually, you will know that this patient is not doing well. You can see a lot of hypoglycemias and a lot of highs. So the patient has highs and lows, even though the patient's HbA1c is still 6.8. So in our eyes, if I just see the HbA1c, I'll say the patient is doing well. But if you look deeper into it, you realize that the patient is not doing that well, right? And you see the third patient, right? This patient has an average glucose of slightly lower, 111, but look at his readings, perfect, pristine, everything is within the range. A little bit again, a Gujarati, you cannot, like I said, pre-dinner highs, you cannot take a Gujarati away without this. There is no CGM I have which does not have this. So there's slight little peak, post the evening snack, but rest of the time the patient is doing fairly well. So the idea here is to show you that all these 3 patients had an HbA1c of 6.5 to 6.8, but if you see under the hood, if you put a professional CGM, you realize that all these 3 patients are not the same. They are completely different in terms of their glycemic profile. So blinding has its own importance. If you can recognize, this is Sandra Bullock, a very famous movie called Bird Box, something like that. So why is blinding important, right? You'd always say that I can do everything, all of these, using a real-time CGM as well. But blinding is important because blinding removes a bias. And what is the bias? Look, if I realize that if I have hyperglycemia every day, perhaps I'll start taking corrective measures, but I'll not get the real reason what the problem was. So using a professional CGM once in a while really blinds the patient and blinds, you know about clinical trials, right? What do clinical trials do? They have a blinding process where the investigator and the subject is not aware of what's going on. The same way, a real-time CGM, consider it like a RCT. What you're really looking at is that both the investigator, me, and the patient is not aware about what's really going on. But when the patient comes back to us, you get the data, then you sit with the patient, you analyze the data, and you find the problems, right? You find the problems and then you deal with the problems, right? So hence, blinding has its own importance in a sense, because if you keep allowing the patient to correct every time, you really don't come to the root of the problem and the patient continues to face these issues. So again, a flash CGM or a real-time CGM definitely is the preferred option, but sometimes a blinded professional CGM has its own place in the world. So what are the indications of using a professional CGM? A patient having very high HbA1c, typically HbA1c of 9, 10, 11, you would consider using a CGM to really look at what's going on. Very importantly, when you have discordant HbA1c and finger stick glucose reading, right? So a patient comes to me with an SMBG reading which is pristine, but the patient's HbA1c is 8, right? What's going on? I really want to know. If you want to make a change in the diabetes plan, the patient is on a basal bolus insulin, you want to change the patient to basal plus GLP analog, right? Can you do that? Have a look. Patient has renal impairment, patient undergoes dialysis. Patient is undergoes chemotherapy. You really want to see what happens every week. You can do that. Patient continues to have frequent hypoglycemia or has hypoglycemic unawareness. Professional CGM is very useful. Patients with gastroparesis, you want to know what's going on post meal. Very useful. Patient does not follow recommendation for finger stick glucose. Believe me, I have patients like this. He said, I will not do finger stick glucose, even if it kills me. I mean, that's the level of resistance that such patients will really benefit by putting a CGM once in a while. Sometimes you can do annually, like Dr. Unnikrishnan sir said, every 3 months or every 6 months. Have a look at what's going on with the patient to get a blinded, a fair data of what's really going on. And most importantly, to get the data about time in range, because I very strongly believe that HbA1c is eventually going to be replaced by time in range, because I still really believe that time in range is a better parameter of glycemic control than HbA1c. So this is where professional CGM really helps a doctor. It helps you understand your patient better in terms of behavior, in terms of compliance. It helps you understand the impact of various insulin and anti-diabetic medications. When I started my own practice, I used a CGM a lot. So it really helped me learn more about, how does an acarbose work? How does a GLP analog work? How does a particular SU work? How does the other SU work? How does a basal insulin work? How does a premix insulin work? So all these things really, you learn better. You become a better clinician, you become a better diabetologist, you become a better endocrinologist, you become a better better diabetes educator if you are one. If you really see a lot of CGM. The more CGMs you see, the better you understand diabetes as a disease itself. It generates a lot of data for a clinical audit. So, every few months I sit with my CGM data and look at what's going on. How is my patient doing? What are their GMI values? What are their HbA1c values? It really helps me do that. Most importantly, it helps you predict the future HbA1c result. I think this use case was really discussed by Dr. Joe in one of those patients who required a surgery and required glycemic control early on. So all these things are very useful for a clinician or a doctor to really look at, right? How does it help the patient, right? For the patient, they get a better understanding of their own glycemic control and their own good and bad practices. They really realize what is going on, where they're going right, where they're going wrong, what food really caused a problem, what food was really good for them. All these things really helps them understand. It removes some of the myths this patient have about diabetes management. A lot of these patients, have a lot of myths, have a lot of, for example, very difficult to make patients understand that jaggery is as bad as sugar. But you put them on a CGM, they take a jaggery, they'll note it down, they'll show you the chart, and you show them that what's really happening after jaggery, after their, what's the post-meal surge after the jaggery or after their honey, and the patient is then convinced that it's not what they used to believe was really true. So what's the importance of time in range? Time in range is the percentage of time the patient spends between a value of 70 to 180. This is the classification of the various data. So you have time in range, they have time above range and time below the range. So what is important is that now there is emerging data to show that time in range has correlation with diabetes related complications. And what other, on the other hand, what data has also shown that a lot of type 1 patients now have started understanding time in range better than HbA1c, and they give more importance to time in range. For them, time in range actually matters more than HbA1c, and hence, from a patient driven side also, time in range is becoming a very, very important parameter. Time in range is very useful in patients where HbA1c is unreliable. For example, patients with CKD or hemoglobinopathies and so on and so forth. It's very useful when you want to see a glycemic pattern for a relatively short period of time, like say COVID-19, etc. And it reflects hypoglycemia much better than HbA1c, that is for sure. And by nature, remember, pregnancy is a shorter period of time. So by nature, it's very useful in pregnancy because you are dealing with different trimesters, changing scenarios, and hence, these things become very, very useful. So overall, time in range is an emerging area of research, and now you have more and more data to suggest that time in range does correlate with diabetes, micro as well as macrovascular complications. Also, now we have data to suggest that the pregnancy outcomes are also associated with good time in range. So I'll tell you how we use professional CGM in our practice. What is our workflow? So like I said, we typically use CGM for fine tuning glycemic control, to give that extra edge, to give that extra X factor, to give that extra impetus to get slightly better glycemic control than what the patient is probably having. So what we do is, when I see a patient, typically I see a patient with HbA1c of 9, 10, 11, sitting in a tertiary care center, you tend to see more complicated patients. So you start this patient on oral antidiabetics or insulin. You adjust the dose of your oral antidiabetics or insulin to achieve a target fasting. So my first aim, like Dr. Uni sir talked about the My Dose coach. Well, I don't use My Dose coach because, what I use is a simpler technology, which is WhatsApp. Right, so I ask the patient to check the sugars daily and send it to me by WhatsApp. I titrate the dose of insulin or the oral antidiabetics to achieve a target fasting in a range of 90 to 130. That's my first target. So once I have the patient who has achieved a target fasting blood glucose, then I call the patient back and I put a CGM. And that is where, we wait for 15 days, we call the patient back, take the CGM data, sit with the patient, discuss where the patient is going right and where the patient is going wrong, discuss how much HbA1c we can anticipate, and then fine tune those things, correct those things, give specific ideas of how the patient can manage their sugars better, how they can manage their diet better, how they can manage their medications better, and then eventually get a better control, probably do a follow-up CGM, and then eventually call the patient up for after 3 months for an HbA1c. So this is how I typically use CGM in my practice, and it really helps my patients to understand better, and most importantly, it helps my patients achieve a better HbA1c without hypoglycemia. Right? So I'll give you some case studies to really discuss how this has been really useful. Some really interesting cases where it will give you real life cases of real life use cases for using a professional CGM. So let's say this patient, right? So this is a patient. What happened was that this patient had a fasting sugar which was 105 or 95, thereabouts, and the post meal values, so the patient used to have a slightly late lunch, about 2 o'clock in the afternoon. The patient used to feel hypoglycemic before lunch, which never was checked on SMBG, and post lunch the patient had sugar values of 95 and something like that, right? So if you look at from a patient's perspective, the patient is having fasting, which is fine. The post meal, which is actually post lunch, which is slightly on the lower side, but the patient's HbA1c, you would not believe, was 8, right? So what was going on? So what we did was, so there was a discordance between the SMBG reading and the the HbA1c reading. We asked the patient that why don't you check your sugar in the evening time or pre-dinner or post-dinner, something like that, but the patient simply refused, saying that, look, I don't have the time, that is a different time, I'm busy, I may not be able to do it. So we put the CGM, and what we found was exactly the problem which was going on. So what happened was, the patient was developing pre-lunch hypoglycemias, but then patient used to get hungry after lunch, after some time, possibly hypoglycemic, and hence, patient would have a lovely Gujarati snack in the evening, right? You would not believe what he ate. And look what happened after that. The sugars used to shoot up, a lot of glycemic variability, and then again, come down again eventually at the period of time. So we recognized the problem, we dealt with the problem, and we could offer better glycemic control to our patient. Second patient, right? This is a patient with a type 1 diabetes, young patient, 20-year-old patient with type 1 diabetes, who was on twice daily pre-mix insulin, and he was convinced that pre-mix insulin is the only way of treating type 1 diabetes, and we tried to convince him that basal bolus insulin is better, but he refused to understand, he refused to acknowledge that. So we did something better. We put the patient CGM of the patient. The patient, what he used to do, he used to check his morning, he used to get up late in the morning, he used to check his morning sugar, which used to be around 140, 150, and he used to check his post lunch sugar, which was around 2 o'clock, where it used to be around 200. You say, my fasting is 140, my post lunch is 200, I'm doing very well, I don't need basal bolus insulin. So what we did, we put the CGM on this, and look at his glycemic control. It's absolutely topsy-turvy, right? You can see that he's developing he's taking insulin in the morning. Look at the dip here, look at the highs in the evening, right? It's completely messed up, right? So as soon as the patient had a look at this, he realized what the problem was. He realized that his pre-mixed insulin is not going to work for him. So he was convinced to switch to basal bolus, and look at this fallout, right? So this is after the patient was switched to basal bolus insulin. I'm not saying that we have a perfect glycemic control, but just see these two pictures and you'll realize that the difference. Not to like this is somewhere in the April, patient was convinced, you put the CGM again, and this is somewhere in May, and you can see within a short period of time the glycemic control is completely changed from HbA1c of 10 to HbA1c of 6 estimated HbA1c of 6.1. Very few hypos, very few hypers. Patient is doing much better. This still requires fine tuning, but he's still doing much better than what he was. So this is a use case. Nowadays, we see a lot of patients who are this is a COVID era. We are seeing a lot of use of dexamethasone, and we wanted to see really what is the impact of dexamethasone on glycemic control. Steroid-induced hyperglycemia is one of my area of research for a long time. It was my thesis topic. I continue to track this as a very important disease, and COVID actually gave us a lot of impetus because steroid was used left, right, and center, right? So this is an interesting paper recently published which talks about the glycemic profile of intravenous dexamethasone using a CGM, and what they found was they found a triphasic pattern. So they found a hyperglycemic peak which starts 3 hours after the use of dexamethasone. So all the physicians who are listening to this is going to be very useful to you, because if you're dealing with COVID patients, and dexamethasone is the steroid of choice in COVID as per the studies. So this is something which will prove very useful to you in your practice. So this what this case report showed, that the patient had a hyperglycemic peak starting 3 hours after dexamethasone, which lasts for 24 hours. After 1 day, it starts normalizing, right? And again, this normal period lasts for about 14 to 21 hours. And then there is a second plateau which starts after 2 days, and it lasts for about 7 to 14 hours. So this is using a single dose of dexamethasone. This patient was on chemotherapy, very similar to another patient I'll show you. So this patient was on chemotherapy, was receiving weekly doses of dexamethasone along with the chemotherapy, and after this there is normalization, but there are some small plateaus which you can see from the figure. So this is the first peak which happens, right? So the patient is receiving dexamethasone, the patient has a first peak, then things tend to start normalizing after a day. Then there's a second peak, and then there are small peaks which go on throughout the entire week. So this is what typically they found as far as dexamethasone was concerned. I'll tell you what we found. So we analyze our own data. So as soon as I saw this, I asked my diabetes educator, who is an assistant to me. I asked her, why don't you pull out that file of that patient, who takes weekly dexamethasone for a chemo, and she's on, we put a CGM once for her, and look at what happened, right? So this is non-chemo day, chemo day, right? So patient is on a chemo day, patient received dexamethasone. You can see the peak very similar to what this paper talked about. So there's a peak. So this is first day after chemo, the peak is still there. So the overall average sugar is still high, but it starts to normalize. So our patient, I think there's a difference in terms of glycemic management, and of course, what the patient is eating and all those things. But in our data, what we are showing is that after 24 hours, it tends to start normalize. This is very similar to our thesis, what we had done. So what I'm trying to show you is that dexamethasone tends to have an action which lasts for almost, you can say, for almost 14 to 18 hours after it has been given, and you should anticipate that is a period when hyperglycemia could persist, right? This is another patient on steroid. This is a patient on post-transplant patient on morning dose of prednisolone, right? I'll show you another picture of that very similar, which we just saw yesterday. So I just rushed in and put in that slide. So this is a patient who is on a post-transplant, who is on a prednisolone. You can see there is a post-meal peak, which you can see in this patient, right? Again, another patient on a morning prednisolone dose with a slightly lower morning prednisolone dose. These are post-transplant patients, right? You can see morning he's developing hypoglycemia, but post-lunch he's developing a slight hypoglycemic peak, and post-dinner also, post-evening snack, not dinner again. For Gujaratis, evening snack is like a dinner, right? So, you again tend to have a slight peak here. This is a patient just with gestational diabetes on multi-dose insulin, basal bolus insulin. We use a lot of CGM in pregnant patients. It really helps them. And remember, they are in a shorter time frame. We need to achieve good glycemic control in a shorter time frame. So, and CGM is very, very useful in such patients. This is a patient which baffled us. This is an old patient. 2019 patient. Really, we did not understand. We did everything right. The patient's fasting was always good. But really we could have no idea what the patient was going through. So we put a CGM, and what we realized is that the post breakfast, sugars used to settle down in the morning time, but the patient had a very big peak post breakfast. Patient was a businessman by profession. He used to have a brunch early in the morning, before he used to leave for work. And you can see there's a big peak over here. So we added a short. Patient was already on a basal insulin. We added a short acting insulin before his breakfast, and that corrected the problem, right? And this is the patient I talked about. I just saw this patient a few days back. This patient is on a morning dose of 10 milligram of prednisolone. You can see what is happening here, right? So he's developing a post-lunch peak, which is very, very typical of steroid use. So professional CGM is very useful for patients on steroids or on other agents which can potentially alter the glucose pattern. Like tacrolimus, some of these post-transplant patients will be on cyclosporine or tacrolimus. Really, if you want to understand the impact of this, CGM is very, very, very effective, right? So just to summarize some important take-home messages for you, professional CGM continues to have a role in modern diabetes management. It is very useful. It has its own use cases, and I really believe it should stay because it is cheaper also. Remember, professional CGM is, compared to a real-time or a flash CGM, continues to be cheaper. Professional CGM is very useful for fine-tuning glycemic control rather than to build up diabetes treatment program. So it's better for fine-tuning, for getting that extra X factor, extra edge over glycemic control, and try to perform a professional CGM at least once a year, very similar to what Dr. Unni sir said, on your regular diabetes follow-up patient to gain more insights into their behavior, into their practice. And most importantly, I'll tell you, it will make you a better clinician. It will make you a better diabetologist or an endocrinologist or a diabetes educator. It will actually enhance your practice because you learn a lot of patient behaviors from the CGM data. Thank you so much for a patient listening. Thank you.